This is Major Mark. Thank you so much for joining us with these webinars. This is a schedule, the upcoming schedule for the rest of the month of May. And if you need to find the replay, all of our webinars are going to be on this YouTube site. And as well, check out our Instagram, which we're going to be pushing live feeds and mentoring. So without further ado, we're going to be listening to Capt Jolivet and Major Sylvain present on PPE.
So in delivering today's webinar, we just like to emphasize that we are aware that a lot of the information that we're going to share today is going to be familiar to all of you, particularly those of you who have been attending the unit teleconferences. And we also recognize that our experience won't necessarily be universal and that every detachment has their own reality, but we still see this as a useful exercise for everybody and an opportunity for us to consolidate all of the lessons learned in the 2 months or so preceding. And in the spirit of consolidating lessons, following today's presentation, we'd be happy to receive any recommendations or feedback regarding best practices from other detachments. So as you can see from today's outline, our plan is just to walk you through our approach to managing patients right now, with an emphasis on the safety practices and administrative procedures we've erected in the wake of the COVID-19 pandemic. So presently, we'll touch first on remote triage. So presently, Det Borden is staffed on a weekly rotating basis by our duty team, which consists of 1 captain dental officer and 1 dental technician. And during their tour of duty, as it were, they keep regular hours at the detachment. That is, they're present from 7:30 to 3:30 and remain available as ever on a 24/7 basis for care. The command team is often present also during working hours, but this is not consistently the case. So because these teams are often working in isolation, we emphasize at our attachment the need for clear and open lines of communication. And because of that, every week, the outgoing team will provide a brief to the incoming team by email, which will summarize any changes with regard to equipment or protocols that have been introduced in the week preceding, and also listing each of the patients that we treated that preceding week, whether remotely or in person, and what treatment they've received thus far, since it'll have to be a stepwise treatment. Also in this spirit, we've put together a PowerPoint presentation that serves as a living document that summarizes everything that we're doing right now. And the team will also review that and update it as needed so that they have a manual to work from as well during their week of duty. So currently, our members are accessing care by contacting our duty team directly by telephone. And as I'm sure you're aware, some weeks ago, the Chief Dental Officer promulgated a directive providing clear direction as to whom we can and cannot see and the conditions under which we can see those members. And so our first order of business is always initial patient triage. That is, our patients presenting with what would be an urgent or emergent dental condition, and also what is their relative risk of transmitting the COVID-19 virus. And so Annex B provides a clear pathway for patient treatment that you can follow. You'll notice this annex differs slightly from the initial annex that was released, and this reflects the recent introduction of air filtration into our daily practice, of which we will have more later in the presentation. So presently, as I'm sure other detachments are doing, we're only seeing those patients that are deemed low risk with respect to the transmission of the COVID-19 virus, and among those, only those that have an urgent or emergent dental condition that we're not able to treat remotely. And so, of course, wherever possible, we try to treat our patients initially remotely, often by pharmacotherapy. And a lot of our dental officers have found the protocol released by Dalhousie University useful in directing that initial management. And we'd like to give recognition to Major Mark and Major Mendoz during this tour for bringing this to our attention some weeks ago at the first endo webinar. We're also fortunate in that in our geographic area, we happen to have a number of facilities that are capable of and willing to see members suspected of having or confirmed to have COVID-19. And we're also fortunate in that to date, we've only had occasion to direct 1 member to an external provider. As an added layer of protection, our detachment is co-located with 31 Canadian Forces Health Services Group. And as you can see in these photos, our medical colleagues have erected a remote patient triage site. And during typical working hours, any patient seeking to access either medical or dental care has to pass through the site in order to enter the building. It's staffed by a team of medical technicians that are provided with standard PPE, and they screen their members with respect to their relative risk. And from there, they're either permitted to access care or they are seen by a medical officer for further assessment outside the building. They're directed to self-isolate or directed for further testing. As an added bonus, this also serves as a drive-through pharmacy. So when we do provide that initial pharmacotherapeutic management, our protocol is to hand deliver the prescription to our base pharm, who in turn passes it off to the medical technicians, who in turn pass it off to our patients, so that our patients can receive their medication without ever having any reason to set foot in the building. So, as you know, our patients should be initially accessing care by telephone. However, we've had isolated cases of members presenting to medical for an unrelated medical complaint and then presenting to dental for a dental complaint. And for this reason, we keep our clinic door locked during working hours. And on arrival to the clinic, they encounter the following signage on the right here, which just directs them as to our mandatory triaging and distancing policies and directs them to contact the duty team to access any care. So that more or less covers off our approach to patient triage. So from here, for those cases where we do feel that we need to see a patient, we have to touch on patient reception. And it differs during working hours vice outside working hours because our resources are a little bit different. So during working hours, we arrange for our patients to contact us by telephone in order to access the clinic following screening by our medical colleagues. And then our duty dental technician will greet them at the door. As you can see, we've cleared our reception area of any unessential furniture to facilitate physical distancing. And our reception area presently only accommodates 2 patients, which reflects the number of operative bays that we have available. In principle, all of our patients should arrive having been screened, completed hand hygiene, and having donned a mask, but that hasn't universally been the case. So on the lower right, yeah, you can see this little hygiene station that we've set up. It consists of a tray and an alcohol-based hand rub, and we just direct our patients to follow these directions and wash their hands, don a mask, and avoid any unnecessary contact with our treatment services or our building services. Also, when they're greeted by our staff, our staff will be protected by a type 1 mask and eye protection. And as an additional layer of protection, we've recently erected these plexiglass barriers at our reception desk. Our members will also encounter the following signage, again, just directing them with respect to our mandatory distancing and triage policies. Outside working hours, we have to conduct ourselves a little bit differently in that we don't have our medical colleagues to give us a hand. And so we choose to receive our patients through our rear staff entrance because it is equipped with a large vestibule that facilitates physical distancing and also has touch button entry so that our patients have no reason to handle the doors before they've completed hand hygiene. In the vestibule, our patients will find a cart with an alcohol-based hand rub and a mask and the signage as above. It's not pictured here, but on the left, there's also a field sink and hand soap. If their hands happen to be visibly soiled, or if they prefer, they can wash with soap and water. So following hand hygiene, as when they're received during working hours, temperature is taken and they're directed at an appropriate physical distance to our reception area. So having touched on all that, we'll move on to watch a video that summarizes everything I've just described. So if the sound quality is not great, it's because it's just being picked up with my mic. However, we will be sharing the videos shortly after the presentation and the slides so that you can share this with your members and the sound quality should be much better. And here we have a brief video consolidating everything discussed with regard to patient reception. You'll note here that our duty dental technician, played by a worn med canon, is protected by safety glasses and a type 1 mask. This is recommended whenever physical distancing policies can't be respected at all times in the workplace. That is, when a 2 meters distance can't be respected at all times. It should be noted, however, that the mask must be exchanged at a minimum every 4 hours. Our patient, played by Corporal Maldonado, is directed to the hygiene station, which follows directions to carry out hand hygiene, don a mask, and repeat hand hygiene. When it's complete, our dental technician will complete the visit. Our medical colleagues have lent us an infrared thermometer, which permits us to maintain maximum distance while obtaining temperature. If the patient is confirmed to be febrile, finds a temperature below 38 degrees Celsius, she is directed to take a seat until the duty team is prepared for the procedure.
You'll note that a reception area has been cleared of all non-essential furniture to facilitate this. You'll note that when a duty dental officer, played here by Captain Lee, is ready, he too is protected by masks and glasses, and respects physical distancing while directing patients to the operating room. Outside working hours, we conduct business a little differently. We receive our patients at a rear staff entrance, where a vestibule permits us to maximize physical distance. A wash basin with soap, visible on the left, and a cart with an alcohol-based hand rub is placed here. Again, the patient carries out hand hygiene, dons a mask, and carries out hand hygiene again. And once your temperature is cleared, the member is escorted in appropriate physical distance to the reception.
Okay, so our profession happens to be among the highest risk with regard to the transmission of this particular virus. And so it's incumbent upon us to take all the necessary measures to protect both our own personnel and the members we support. And one of the most critical aspects of that is the sort of central topic of today's discussion, which is personal protective equipment and the correct selection and use thereof. Okay, so per the CDO's directive, we select our PPE conditional on whether or not the anticipated treatment is high risk or low risk. And of course, as I'm sure most of you know, one of the key factors is whether or not aerosols will be generated during the anticipated treatment. It's worth emphasizing here that because we want to minimize the number of times we change PPE, because the time that we doff PPE is among the highest risk, it's better to err on the side of being high risk or low risk if there's any ambiguity as to which it will be. So we've arranged all of our PPE in a dedicated PPE station, which is located some distance from both of the operational bays that we have right now. And in that station, all of our items of PPE are organized in the sequence in which they are donned, with aide-memoire placed conspicuously so that there's no confusion as to what materials are required and as to how they are to be donned. This is the PPE indicated for low risk treatments. You'll note that the mask ought to be a level 3 mask and that the gowns can be level 1 or level 2. A number of providers have inquired as to whether one can safely wear loupes during treatment because, as we know, a lot of treatments are difficult to perform with the naked eye. I've done an endo during this without loupes and it's terrible. The answer is a tentative yes. As a recent update from the CDO indicated, we don't have a lot of solid empirical evidence as to the safety of this practice, but indirect evidence suggests that our conjunctiva can be contaminated with viral particles during close contact treatment. And so we can use loupes as a standalone treatment during low risk, as a standalone protection during low risk treatment, but you'll want to have side barriers on your loupes. Mine, for instance, don't have that. And if you don't have that, it's better to support them with a face shield. You can wear loupes for high risk treatment, but as modeled here by Major Plass in the second from the right, you'll want to support them with a face shield that extends below the chin inferiorly and beyond the angles of the mandibles laterally. Alternatively, you can wear a face shield and safety goggles and loupes with loupes attached to a headband extending over the face shield, and that's modeled by Major Elliott on the far right. And this is the sequence for donning low-risk PPE. Nothing terribly surprising, I would think, here, except it's worth emphasizing that hand hygiene does need to be repeated before donning your gloves, and your gloves should extend over the sleeves of your gown. And once you've donned your gloves, you want to respect a no-touch policy and minimize contact with other surfaces. And this is the PPE indicated for high-risk situations. You'll note the introduction of an N95 respirator, which is a very topical subject right now, as well as a surgical gown, so level 3 or 4, surgical gloves, bonnets, shoe covers, and slippers. And again, worth emphasizing, your patient should also be protected by a surgical gown or some other barrier. And this is the sequence for donning high-risk PPE. Just points worth emphasizing, you'll want to repeat hand hygiene after donning your booties and again before donning your gloves. It's also worth emphasizing that your N95 respirator is not just another mask, and it needs to be appropriately fit tested as there are multiple sizes. We're fortunate at our detachment in that everybody happens to wear the same size respirator, but that won't universally be the case. So you'll want to ensure that you're wearing an appropriately fit tested respirator and that you perform a seal check prior to commencing treatment because an adequate seal is critical for protection. You'll don your N95 respirator by extending it over the nose and under the chin, and then securing your straps. The upper strap should extend to the back of the head above the ears and the lower below the ears around the neck. You don't want to crisscross the straps. Once secured, you mold it to your nose until you can achieve a seal, and then you'll perform a seal check, ensuring that there's no air escaping around the mask. If you can't achieve an adequate seal, don't be embarrassed to ask for help or try another size respirator. And we will move on to another video. I apologize for my William Shatner-esque narration in the video. That's just what the editing did to me.
And now we present a video that touches on the central topic of today's discussion: transmission-driven personal protective equipment. We'll touch first on the sequence for donning low-risk and then high-risk PPE. As discussed earlier, we've established a dedicated PPE bay at Det Borden, which provides a dedicated area for donning PPE some distance away from the areas where we generate aerosolized particles. As you can see, we've arranged our PPE in the sequence in which items are donned, with aide-memoirs placed conspicuously to guide our person. Our detachment, as do others, perform quarterly hygiene audits, so we expect that our hand hygiene technique is sound. All the same, we've placed guides to hygiene with both an alcohol-based hand rub and soap and water at the sink. Sanitizer does effectively kill the virus, but it's recommended that proper hand washing with soap and water be substituted for sanitizer approximately every 3 washes, or if the hands are visibly soiled. We begin with the sequence for low-risk PPE. Gowns serve to protect both skin and clothing and should cover both. The gown should cover both the front and back of the torso, extending to at least the knees and fitting comfortably over the body with long sleeves that are fitted at the wrists. Goggles should fit snugly over and around the eyes. It's not acceptable to substitute one's personal glasses for goggles, and the goggles selected need to be side-vented. Once mask and goggles are in place, it's essential to limit any opportunities for touch contamination. Don't touch your face or touch PPE with contaminated gloves. Remember to perform hand hygiene again before donning your gloves. Ensure that the sleeve of the glove is fitted over the sleeve of the gown. Once both members of the duty team are suited for battle, we conduct a buddy check to ensure that everything has been placed correctly. And now we demonstrate the sequence for high-risk PPE. You'll note that our duty team has already completed hand hygiene, placed buoys, and is now hand washing again. They will now don a Type 3 surgical gown. Please note that subsequently in this video, one of our providers will don a surgical mask, device, and N95 mask, as we wanted to minimize the number of masks used in the production of this presentation. Both providers must wear an N95 mask if it is anticipated that aerosols will be generated. Note that Captain Lee verifies that the N95 is correctly sized before donning the mask. You will note the placement of the straps, that they are not crisscrossed. You will note that he molds the mask to his face and, having done so, conducts a fit test. Our providers will next don goggles, a bonnet, and a face shield. Surgical gloves will be used in lieu of examination rooms for high-risk procedures. Again, ensure that the sleeve of the glove is fitted over the sleeve of the gown. Again, we execute a buddy check before proceeding to the operatory.
Now, those of you with keen eyes may have noticed that our face shields didn't extend all the way below the chin or beyond the angles of the mandible, and that's just all we had at the time. So we'll move on to the topic of doffing your PPE following treatment. And it's definitely worth emphasizing here that this is a step that needs to be performed with care because the risk of contamination here is fairly high. Also, if you have happened to look online for direction with regard to the selection, donning, and doffing of PPE, you'll note that there are multiple acceptable approaches of doffing your PPE, and what we're about to demonstrate is just one of many. However, we choose to teach our providers a single method just for consistency, because we find it's more effective for people to perform one method consistently rather than mixed methods. And also by having everybody standardized, we can ensure that we check one another for correct technique. It's also worth emphasizing that these movements need to be performed carefully and with minimal agitation, because that can have the effect of resuspending viral particles. So the method we treat the method we use is this one. So in both of our active bays, we have dedicated doffing stations adjacent to the door. Again, with aid-memoir placed conspicuously so that nobody has to worry about memorizing anything. So our first order of business is to remove our booties with gloved hands, and with our hands still gloved, we'll then remove the gown. And this is probably the more complicated aspect of this. So you want to pull the gown forward such that the ties break in the back. And then as you're pulling it forward, you want to roll it inside out with the contaminated surface facing out, and then pull off your gloves simultaneously and dispose of it in the garbage all at once. Having done so, you'll have to repeat your hand hygiene, and then it's time to remove your face shield and your bonnet. Here, the point worth emphasizing is that you want to remove the face shield and the bonnet from the rear, vice the facial surface, because of course the facial surface is the most contaminated surface. Hand hygiene is then repeated after discarding. And now you're going to exit the operatory. It's important to close the door behind you because you want to contain any suspended viral particles. Outside the bay, we have a secondary doffing station, again with a table, garbage bin, and a disinfection bin for items that are intended for reuse. Hand hygiene is repeated, and the eye protection again is removed from the sides vice the face. And these are placed in the disinfection bin, which is lidded for subsequent disinfection. And now it's time to remove the N95 respirator. So our very talented model in the video to follow removed it by the face. That's generally not what you want to do. We just didn't want to waste multiple masks in making the production. You want to remove it by the straps leaning forward and then place it in the garbage. And then hand hygiene is repeated and another type 1 mask is donned. And we will watch another short video again just to consolidate all of that.
This next sequence, we'll see our treatment complete and a provider prepared to remove PPE. A provider moves first to the doffing station adjacent to the door, where an aide-memoir will guide removal of personal protective equipment. As you can see, booties are removed first with gloved hands. Following this, with gloves still on, the gown and gloves are removed simultaneously if possible. Following removal of these contaminated items, hand hygiene is repeated. Now our provider will remove the bonnet and the face shield. You'll want to remember to grasp the rear of the bonnet and the strap of the face shield, as these are the relatively thin surfaces of these items of PPE. Before opening the door, hand hygiene is repeated. And it's important to remember to close the door behind you to contain any suspended viral particles. Our provider has moved to the secondary doffing station where hand hygiene is repeated. Eye protection is removed by the straps, not the facial aspect, and placed in the disinfection bin as these are intended for reuse. The N95 is removed by the straps and not the facial aspect of the mask as the member does here. Hand hygiene is repeated and a type 1 mask is donned.
Okay, moving forward, we'll touch on operatory setup. So we're fortunate at Detachment Borden in that we have 2 closed bays, so that not only can we treat patients, but we can treat all of our patients, be they low risk or high risk procedures in a closed setting. In both of those bays, we removed all non-essential furniture to minimize the number of potentially contaminated surfaces. And before treatment, we place barriers on all peripherals, such as radiography equipment and computers. As was noted in the previous section and previous video, we have doffing stations just outside both those bays.
Hey, Aaron.
Yep.
Darcy Cormier has a question just about thoughts on double gloving that she's heard about on other PPE presentations. Have you guys talked about that at all?
That's not a practice that we are currently using. I might defer to Warrant Medcalf on that if she has any idea whether that was discussed with the sir previously, but I'm not aware of us ever considering that.
For right now, no, we're not double gloving, but it's something we could definitely look at.
Major Holdren, are you aware of any added benefit regarding that?
That's a really good question. It's come up in some of our research, and I'd have to look back to see the pros and cons. I knew there were definite downsides and upsides. But I think we're one of the few institutions that are recommending surgical gloves. So that's certainly like one step up from your usual exam glove. But I'd have to get back to you guys on that.
Scene. Any other questions?
No, that's it right now. Thanks.
Perfect. No problem. So as you can see from this sort of panoramic photograph, we've just stripped our bays of any non-essential furniture, not pictured here, but what would be on the tray prior to treatment would be a small sort of Dixie cup with hydrogen peroxide-based rinse and 3 pieces of Kleenex in a Ziploc bag. The purpose of all of that we'll explain momentarily. Also on our countertops, we'll have 2 fresh type 1 masks. These are present in case we do have to leave the bay for radiographs, though we do try to avoid that wherever possible, and the second for patient dismissal. These are protected with a patient bib with the non-absorbent side facing up during high-risk treatments. Again, I don't really need to harp on this, but yeah, we have the Doffing station just outside the operatory as well. And a recent introduction into our daily practice is the air filtration units that we'll discuss more at length shortly. But the one at the foot of the patient chair on a day that we are treating patients should be active all day long, and the larger unit beside the patient will be ready to go just before we see our patients as well. So once aerosol generating procedures, so high-risk procedures, are underway, we'll place the signage on the left on the door, just forbidding any staff from entering once treatment is underway, because we do have janitorial staff frequently circulating throughout the day, at least during working hours. And the signage on the right, of course, just advises our personnel as to when the room can safely be entered for disinfection and sterilization. So as I just mentioned, our detachment is one of 5 detachments that has recently been outfitted with a pair of air filtration units, which function to reduce the viral particles in the air, or the particles in the air that prevailed before treatment began. We are one of 5, but there are other detachments that are going to follow. We're just the first set. So it should be emphasized here that despite the presence of these controls, it's still critical to avoid aerosols wherever possible. So all of the protocols and recommendations of the CDO's directive still prevail. But when we do treat our patients, this is something that's active. So the schematic on the right here just illustrates, again, how these are arranged in the bay. In both pictures, we've depicted the larger medevac unit on the dentist side, but we have confirmed that you can place it on the assistant side if your operators are finding it difficult to maneuver around. It's also worth emphasizing that these are only effective in closed bays, and they are noisy. We haven't had to use them with the patient yet, but we've heard them in operation, but they're not noisy such that you have to wear ear defenders in order to use them. One key point is that when they are in use, once you've finished your aerosol generating procedure, and you're definitely not going to produce any more aerosols, and you put your handpieces away, you have to remain in situ for a full 10 minutes with all of your PPE on before you can doff your PPE and dismiss your patient. Other points regarding treatment procedures. So I mentioned that we have that hydrogen peroxide-based mouth rinse that's on the patient will use before treatment. So once they rinse with that, they'll expectorate into the cup, and they will absorb the fluid with the Kleenex themselves, seal it in a Ziploc bag, and dispose of it. The purpose here is just to prevent our personnel from unnecessarily having contact with what is a potentially infected fluid. Following high-risk procedures, of course, your patients will have to doff their gown or other barrier. We use the gown. Here, we arrange for our personnel to provide direction to not do this unnecessarily aggressively and to minimize the resuspension of viral particles. Following treatment, of course, our patients will have to repeat hand hygiene, don a mask, and repeat hand hygiene again. And then they're advised to wait in the reception area while our staff carefully doff PPE, and then they can be escorted at a safe distance out of the building. A few points regarding radiography. I'm sure most of you are aware that intraoral radiography should be avoided wherever possible, but we do have a portable unit available in the bay if, for whatever reason, it's just a mandatory thing. Where possible, we prefer panoramic radiographs over intraoral just because they don't have the same tendency to generate coughing and generate saliva. Major Meadows demonstrated how PAs can be simulated with a panoramic, and we made a little tutorial and attached that to the pan unit so that whomever is on duty can just review that if they're unsure of how to go about doing that. And before we touch on disinfection and sterilization, one more video. This final video illustrates the
procedures that our patients execute before and after treatment. Before all high-risk aerosol generating procedures, our patients don a type 1 mask, which has been laid out for them in advance, following which they will discard the type 1 mask they will already be wearing. Having discarded the mask, they will then rinse with a hydrogen peroxide rinse, which has been laid out in advance on the dental tray alongside 3 sheets of Kleenex. These are used to absorb the fluid in the garbage is sealed in a Ziploc bag and discarded by the patient in the garbage. The patient is now ready for treatment. Treatment complete. Safety glasses are discarded and the gown is removed under the direction of our personnel, care not to agitate it unnecessarily. And hand hygiene is repeated. The type 1 mask, which is laid out in advance, is donned. Hand hygiene is repeated again, and the patient is instructed to wait for our personnel in our reception.
Again, if you were keenly eyed, you may have noticed that we didn't protect the mask. And again, we just didn't want to go back and waste PPE fixing that in the video. So just some points regarding disinfection and sterilization, particularly with regard to high-risk procedures. So when treatment is supported by an AFU, so the air filtration units we talked about earlier, only 30 minutes needs to elapse before you can safely enter the room to commence disinfection and sterilization. And that includes the 10-minute waiting period that we discussed. It's critical that you close the door, as mentioned before, to contain your particles. In the absence of the AFU, of course, you have to permit 3 hours to elapse. And if you're going to wait 3 hours, it's necessary to pre-spray everything with an enzymatic spray. Once it's safe to enter the room, don low-risk PPE for disinfection. And your first order of business will be to remove the barriers on your peripherals and such like. And then once you've disposed of these, dispose of your gloves, hand hygiene, and re-glove before carrying everything else out as per usual. I'll note that the AFUs that we just showed, these are just disinfected with your standard intermediate level disinfectant, so Cabicide, Option, whatever. And right now, per manufacturer's directions, we are sterilizing all of our treatment surfaces with a peroxide-based disinfectant. And again, I think this is very well known, but ultrasonic cleaners are not indicated for cleaning prior to sterilization right now. And just one final point regarding patient administration. So again, because we have small teams working alone, it's critical for us to keep the communication lines very wide open. So we ensure that all patient interactions are recorded in the CFHIS scheduler. I mean, it should be anyway, but we just emphasize the importance of this so that we know who's been seen and when. Additionally, we emphasize for our providers the importance of thorough CFHIS codes and notes, just what was done, what's been done so far, that sort of thing. The DCO put out an email today, but when you do an aerosol generating procedure right now, you should be using the following dentist codes, and I think a lot of people have been neglecting to do that. So 96301 indicates an aerosol generating procedure that we perform locally, and 96302 is for an aerosol generating procedure that was referred out. So just be sure that you're using the correct codes. And one final point regarding communication: at the end of every working day, there's communication with the deck commander regarding the number of patients seen and whether aerosols were generated and whether the member was referred to a civilian provider. And that brings to an end the presentation that we had prepared for you. Before fielding any more questions, I just want to thank my brilliant acting team consisting of Captain Lee, Warren Metcalf, and Corporal Maldonado. I want to thank them for their great skills and patience. And yeah, we'd be happy to receive any feedback and or questions at this point.
So like I said, a great job there, Captain Jolivet. If you have any questions, there's been a few, put them in the chat. Otherwise, just unmute yourself and go ahead and ask. So my question, then I have a question for you there. How many aerosol procedures are you doing per week on average? I mean, every day is gonna be a different day.
It's pretty variable, honestly. So one week I had like 3 patients, and then other weeks we have none. I've meant to gather like actual data about that. Maybe Major Sylvain or Warren Metcalf have more like precise answer, but I think it's usually like 2 or 3. No feedback? My experience has been tops 2 or 3.
And what are your patients, I haven't had an opportunity to talk to you about this, but how receptive are your patients to these procedures when they come in, do all this change, and anyone else can chime in here as well, how the patients kind of they perceive these change and the increased protection.
I can say that like my patients have had no objection whatsoever, and they usually feel more comfortable receiving treatment because they know that we're taking all these precautions, so they know that it's a safe environment and that we take it seriously. Some of them have been a little bit impatient about receiving treatment when I indicate that we were going to do like pharmacotherapy or some other method for 48 hours before we'll see them. But apart from that, they're all pretty happy about it. I'll let other people chime in.
Okay, that's what I was expecting. Warrant Officer Metcalf, you have any points from your side of the house?
Not really. I think that the presentation that Captain Jolivet put together really showcases how much work is actually entailed in this new process, and how it's important to make sure that every detachment is working with all their people so that everybody feels comfortable when a patient does come in. It makes it a lot easier and better for everyone. So I think that once we get this video uploaded and you guys want to take another look, please do. It's actually very well done, and we're having great results with it. So yeah, I appreciate everyone coming in today. Excellent turnout, and it just speaks to our professionalism and our wanting to learn more about how we protect ourselves and our patients.
A warrant. I saw that somebody had posted a question about whether everything gets disposed of into the regular garbage. I was wondering if you could comment on that.
Yes, sir. So for us here in Borden, we have one main large garbage can within the closed door operatory. And once we are able to enter back into the operatory after the time has lapsed, we finish cleaning the bay, make sure that the garbage is tied, and then that goes immediately outside to the external garbage bins that we have. And it does go into regular garbage, yes.
And then we also had a question as to whether what our protocol is when you need extra material that we didn't anticipate and didn't leave out. And yeah, we do have to don off and redon the PPE. That was the question. So yeah, you kind of have to start from scratch when you do that.
Maybe I'll just jump in here. It's Major Holdren. I just relooked at the information about double gloving, and I wanted to share with everybody. So there is a Cochrane review that discusses double gloving. It's found that when you double glove, essentially you reduce the risk of puncturing your gloves. So that potentially reduces the risk of cross-contamination. But that's mainly for orthopedic surgeons and folks that really need to maintain a very sterile environment. So that recommendation is mainly for the OR environment. When it comes to the dental environment, CDC, Centers for Disease Control in the US, states that they do not recommend double gloves when providing care to suspected or confirmed COVID-19 patients. They do state to continue the use of approved disposable medical gloves in accordance with standard and transmission-based precautions in healthcare settings, and when indicated for other exposures such as handling cleaning chemicals. So basically, the recommendation from the CDC, which is a fairly well-respected authority on disease control and infection control, says that double gloves, there's really no need to double glove. So I can send that link out to the IPAC teams. And yeah, that was a page that was updated on the 30th of April. So it's fairly current.
Thank you, ma'am. Ma'am, you might be able to comment on this next question. One user says, not all rooms have doors. We only have one operatory room with a door. Any idea if the other operatories will be getting plastic seal or zip doors?
Yeah, so I do have some information about that. So DDEN Services is prioritizing the closing of operatories now. So there are several detachments and satellite clinics across the unit that don't have any doors. They have a list of those clinics, and they're reaching out on a one-on-one basis to determine the way forward for closing operatories. So I believe Bagotville, Shiloh, Moose Jaw, St. John's have already been reached out to. And there's basically a priority list with respect to how isolated the detachment is, you know, the amount of COVID cases in that area. Basically satellite clinics that have a main clinic close by will be sort of the last on the list, prioritizing those more isolated clinics without closed operatories. But the priority is to close operatories not temporarily. I mean, that might be one course of action to fall back on, but to go through the local RP ops units and to close operatories with a permanent closure, like an actual wall, drywall wall with a door.
Thank you, ma'am. Another question we had was whether the patient sanitizes with peroxide as well after rinsing. And no, I don't believe we're doing that because they will have already done so at least once before doing that. So at least that's not our practice right now. Any other questions?
Okay, well, if there are no more questions, I really want to thank you to you and your team. Actually, one last point: does Major Sylvain have any points? He's been part of this team as well. The deck commander. You have any points there, Jerome?
No, today objective for this webinar was to share experience. It was not intended to be a perfect demo, and we will be pleased to receive any recommendation from other depth if you see something. So, and I want to say thanks to Captain Jolivet for all the work he has put in his presentation. Yeah, it's a team effort, but the final result was awesome.
Thanks, sir. Yeah, it was very much a team effort. Any thoughts on the availability of doing quick coronavirus testing on site? Hopefully it could help reduce the use of PPE. I'm not aware of any plans for that, but perhaps Major Holdren, you could come
on. Sorry, just to reiterate, make sure I understand the question properly. It was regarding the rapid testing.
Chair side testing.
The chair side testing. It's definitely something that's being looked into, but I don't have any real definitive information as to whether or not it's moving forward. But it's something on the radar for sure.
Thank you, ma'am.
All right, with that, so to Det Borden and their team, thank you so much for doing this. It was a really thorough, well done presentation. Really appreciate it. And you know, as I was watching, it was really neat to see how you guys do things. I think that's what it'd almost be really cool if we all did like a Facebook walkthrough of our debts, because everyone does something a little bit different, and it's really nice to be able to see how you guys tackle this problem. Thanks. So if there are no more questions, we've got Process Emergencies coming up this Thursday at 1100 hours. So you know, even if you're a dental assistant or a hygienist, you may want to see what we're doing, because they're going to be talking about broken dentures and other things like that, how we can repair them. And then we're going to be having non-aerosol extractions next Tuesday with Major Schmidt, and of course our quality and patient safety team next Thursday will be talking as well. So if there are no more questions, do you have any last points, sir, Captain Jolivet?
I do not.
All right, well, I'm going to say have a great week, everybody, and look forward to seeing you again. Thanks so much, guys.
Thanks, everybody. Take care. Thanks very much.